Welcome, everyone. Thank you for joining today's webinar. On behalf of the Centers for Medicare and Medicaid Services, the Administration for Community Living, and the Indian Health Service, I would like to welcome everyone to the Long-Term Services and Supports webinar series. My name is Nicole Pino, and I work for Kaufman and Associates. I will be your moderator today. So today's webinar is titled Stronger Together Dementia Awareness Program. Please note this webinar series is supported by a contract awarded by the Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenter and do not necessarily represent the official position or policies of the Department of Health and Human Services or the Centers for Medicare and Medicaid Services. Today's webinar's objectives are to highlight the role of community health representative, also known as CHRs, in Northern Valley Indians' health efforts to address dementia. Next, to provide a snapshot of current and future program activities. Discuss Northern Valley Indian Health's use of mobile healthcare unit to expand services. Now I would like to pass this on to our wonderful presenters from Northern Valley Indian Health to give them time to introduce themselves. Teresa, please go ahead.
Thank you. Good morning, everyone. My name is Teresa Martins. I usually go by Terry. I'm a registered nurse and have been in the nursing profession for 40 years. My role within Northern Valley Indian Health is the Community Health and Outreach Director, and I oversee the operations in our Chico, Willows, and Woodland facilities. Tanya?
Thank you, Terry. Hello, my name is Tanya Tyler. I am a registered nurse. I have been with Northern Valley Indian Health for a little over a year now. I'm currently the Community Health RN coordinator. I am a tribal member of the Mechoopda Indian Tribe of Chico Rancheria, located here in Chico, California. Jeffrey?
And I'm Jeff Flanagan. I joined NVIH about 5 years ago as a CHR and transitioned to a program coordinator role within the last year.
First, Northern Valley would really like to thank our hosts in inviting us to join and share our program with you. Northern Valley Indian Health is a private nonprofit tribal organization that's been in practice serving many communities for well over 50 years. It initially was started in 1971 back in the small town of Willows, where there was a small healthcare facility established to be able to serve our tribal communities. It has grown now, as we will show you over time, but our mission really is excellence in healthcare services to Native Americans and all community members. Northern Valley Indian Health is governed by a board of directors. We have 4 tribes who are part of our consortium, Mechoopda in Chico, Grindstone Rancheria out in Elk Creek, Yoshidahi out in Yolo County, Brooks, California, and then we have our Quetzaldahi, which is in our Colusa facility. One of the wonderful benefits of Northern Valley is they really look to have their staff give a lot of input. And so when we were looking at how to expand this, we wanted to instill values and show what our values were to our community partnerships. So Northern Valley did a survey and asked all the staff to be able to identify their values. And so we have identified compassion, integrity, respect, customer service, and teamwork as our values. The 2 pictures that you see here on the bottom are our newest facilities. The one is in Chico, California, and the other is in Woodland, California. And then up top, we have our administrative building. It'd be helpful for you to understand where we are. So we're up in Northern California. I love when people say, oh, California. I'm like, well, you have to think about where we are. We're up here in Northern California. So right where that bright red star is really where our administrative building is. And that's in Willows, California. It's in Glenn County. Northern Valley serves 5 counties: Tehama, Butte, Glenn, Colusa, and Yolo. We have in the Tehama County, we have a dental only practice. In Butte County, we have 4 practices. 2 of them are primary care, and it's an integrated service. So we often have behavioral health, dental, community health and outreach, nutrition as part of those programs. We have a children's health facility, a women's health facility, and like I said, 2 primary cares there. Going down to Glenn County is our administrative office, as well as a primary care facility with dental and behavioral health. And then out in Yolo County, we have 2 facilities. One on Court Street is our dental only practice with our school-based behavioral health program. And then at Gibson Avenue, we offer primary care, dental and not dental, sorry, dental's over at Court Street. We offer primary care and behavioral health, and our community health and outreach teams are there. In this picture, you see our mobile dental. Our mobile dental serves our pediatric population. They can often be found in any one of our communities or at a school providing those services. So as I shared with you that I have the oversight of all the community health and outreach teams, and I think it's really important that we wanted to share why this grant kind of fell within community health and outreach. So community health and outreach was designed by IHS to initially serve our Native American population, and that is our priority, is to be able to do that. So each of our main clinics in Chico, Willows, and Woodland has a team that is there to provide care to our Native American population and those living in our Native households. When I first started about 6 years ago, these teams were very small. There was probably about 2 or 3 people in each of that. We have now really expanded to include an RN coordinator who helps me oversee the day-to-day functions of that. And then we have other RNs, LVNs, community health workers or community health representatives, and then we have program coordinators. Each of us really has started as a community health worker / community health representative, and moving forward, I'll just call them CHRs. So we use that all interchangeably because we all really started in care management as well as in some outreach. So one of the ways that we work to provide services is that as our CHRs and move up, they get promoted to program coordinators when we have different grants. I'd like to share with you some of our services. We do a lot of services. As a matter of fact, a little later, Tanya will share with you a calendar. So the multiple tasks that we do include our health promotion. So this team that you are kind of seeing us talk about really was brought over and did our COVID vaccine clinic. So we were the COVID response team. So it's just been the last year that we've really kind of settled back in, expanded some of our staffing priorities, and then really started building our programs. So we'll go out and do our preventive screenings, and that might be more centered around recognizing our Diabetes Alert Day, which is in March, and that is because our Native Americans are more at risk to developing diabetes. So we like to promote, prevention, and then we do these screenings to make sure that they're aware of where their numbers are. We do flu shots for our Native communities. We really promote cancer screenings. Glenn County has the #1 lung cancer diagnosis, and so we are really working to be able to expand out those programs. One of the things you'll see under this one list under health promotion is Dementia in Indian Country, and we'll be sharing a lot more about that program, but that has kind of come in and helped us build how we really kind of take our information and share it with our community members. We also do a lot of community events, health fairs. We do cultural groups, and we have two big gatherings per year where we bring in our community members as well as our partners. And we do one in usually March or April. It's our diabetes gathering. This year we are doing it in April, and we are bringing in Chef Nafai, who will be coming in and talking about how food can be used as medicine for our Native community. And then he'll be sharing with us how he prepares food and shares food. And so we're really looking forward to offering that to our community. And then in November, we do a Native American Heritage celebration, and we open that up, and we've done that a couple years and bring in different speakers who maybe offer some motivation for people to be able to be engaged in their self-health plans. Sometimes it's an opportunity to learn from a diabetic educator. Our team also is very much concerned about being able to provide holistic care. So we make sure that we tap into our injury prevention program. So we have a lot of families within our teams. We offer car seats, life jackets, bike helmets. We do a lot of medication boxes. We have a fall prevention program. We go out and do home safety assessments. We will bring home modifying equipment to keep people safe in their homes. And we like to do more prevention, so we offer a lot of exercises that way. The most part of our focus happens to be around care management. Our elders are a population of focus for us, and because they're very vulnerable to some of the aging processes, we connect with them on a monthly basis to ensure that everything is going okay, and we do a lot of care coordination for them. We have a diabetes registry that allows us to really work with people who have A1Cs that are elevated and have chronic health conditions as a result of that. A lot of times our referrals are from our primary care team. They will also come in from behavioral health, and we've even had our purchase referred care make referrals to us. And they can be warm handoffs in the moment. If somebody's in an office talking with a provider, that provider might just be calling, community health and outreach and being like, who's available to be able to support this person? And that really kind of helps give that person that opportunity to develop a self-management plan and be able to start identifying their health goals. The last little piece that I'd like to speak on this film is really just about our CalAIM Enhanced Care Management. Northern Valley is very proud to know that partnership has offered us that opportunity to be able to expand our care management to any NVIH patients, and we are still kind of working through that program development. As I was talking about our care management, I think that I'd like you to understand that this is really why we look for grants to help us, right? Is to do that really patient-centered care plan. And the grants, when we go to a grant and we apply for it and are awarded it, we get technical support that really kind of helps us develop our program. A perfect example is our fall prevention program. That started really as a pilot program with IHS. They encouraged us to go and to write a bigger application. We were awarded that. I was able to hire a program coordinator who then has really been able to bring that out into the community and really kind of streamline that for our teams and offering that to our communities at each of the Chico Willows and Woodland. But when we look at care management, we look to do a very comprehensive intake. So we might do this visit as a home visit. We could do it as a clinic visit, or we might even meet somebody in the community if that's their level of comfort. We will ask a lot of questions. Some of them are very demographic, but a lot of them really focus on what are their identified goals. And so based on their goals, we will pull in different assessments, but we do have some eligibility criteria that we really like to make sure that people, if they meet that, we put in those screenings. So the stay independent screening, this is a screening where we assess for fall risk, and then we look to see what is their strength of it, and we'll do a sit and stand as a second assessment, so we kind of know how to gear them towards their care plan. That may include a home safety assessment and that home modifying equipment. With our newest grant, Dementia Care Aware, we were able to look at multiple screening tools, and Jeff will spend a little more talking about that. But we elected to do the mini cog because it was very quick for us to do and begin those conversations with the patient as well as with maybe any of the family members and or their caregivers. Another grant that we recently partnered with Glenn County on was around adverse childhood experiences. And we were able to implement within our primary care, being able to do an ACEs screening for our adult population. So they understood that some of what their health or their challenges are related to things that they had in childhood, and that we are here now to provide them with resources and support to be able to have improved quality of life. And one of those programs, one of the staff made was our Stress Busters program, and we'll share a little bit more with you on that later. We often do a PHQ-2 on any intake for medical, and should we need to, we expand that back out to behavioral health. And as part of community health and outreach, we have a medication assisted treatment program with case management services that fall under my operations. And we look to maybe connect those that have substance use concerns back to the primary care, or we do have an addiction specialist who's able to provide that support for us. So what this does is this kind of just shares with you the bigger picture of community health and outreach. And I now am going to turn that over to Jeff. When I hired Jeff as the program coordinator, he had actually been embedded within the community health and outreach. So he knew a lot of our patients. And so he was able to kind of take on the development of this program. Jeff, thank you.
Thanks. So when we started, we really thank IHS for awarding NVIH this opportunity to take a deeper look into caring for the elders within our community. And starting out, it took some time to identify how to approach this project. After multiple consultations with the IHS Elder Care team and community collaborators, we identified the following goals. Firstly, being raising awareness of dementia, identifying the screening tools to be used, and identifying target populations. Under the awareness of or raising awareness of dementia, that led us to taking the cognitive. We began by gaining a better understanding of what local and regional adult services were available. This led us to taking the cognitive health assessment training through Dementia Care Aware organization, which led us to identifying the mini-cog and ADA screening tools. Following this, we wanted to bring education to the community. So in collaboration with the Alzheimer's Association and Passages, our local agency on aging, NVIH hosted some community education sessions focused on 10 warning signs and symptoms of cognitive decline, lifestyle modifications to reduce or prolong cognitive decline, or the incidence of cognitive decline, and how to reframe the mindset for stress reduction. Next, the CHOR team brought this project to the attention of our medical providers and their support staffs, where a barrier was identified that the understanding for dementia diagnosis and evaluation by a neurologist was needed. And through many consultations with the IHS Elder Care team and Dr. Fink, we've learned since then that cognitive impairment can be diagnosed within a primary care setting. We moved on to selecting screening tools. We implemented the use of mini-cog, which is a brief 3-minute screening that assesses for memory, cognitive function, language, visual, motor, and executive domains. And this tool's unambiguous instructions made it very easy to made it a very easy addition to the CHR care management toolkit. And in addition to that, we also implemented the ADA interview screening. This 8-question screening is self-administered. It's preferable to be completed by a third-party person, but the screening can be adapted and administered directly to the patient, and if necessary, over the phone. Following all of that, we kind of had to identify who would benefit most from this population. And so as we began to look at that, we came up with the age of eligibility as 55. This aligns with the definition of elder that the tribal community shared with us and allowed for continuity in our other programs that use an age demographic. So as our CHRs are doing these screenings, and we're sharing with you a workflow of what that would look like. If a screening is positive, all screenings are reviewed by our medical care team. And while the medical team initiates evaluation, the CHR starts off with that warm handoff. And that could be either making that phone call following a screening or accompanying the person to the schedulers or reception for scheduling, while also providing education on steps of evaluation, supporting the person with navigating healthcare and resource systems and addressing accesses to care, coordinating referrals, and engaging in modifiable risk factors. And if the screening is negative, the CHR team still provides a lot of those same services and needs assessments. And as an example, we're sharing today a self-management goal worksheet that allows for more concrete goals for patients to identify and improve on their health. And as part of supporting the person with healthy lifestyle modifications, Tanya will go ahead and provide a snapshot of current and future programming.
So as Terry mentioned, I have provided a calendar with images of our programs. So as I review these programs with you, you will be able to see them on our calendar and how we implement them into our programs. So we invite our patients, as part of our patients' health plan, we invite them to our programs to learn about lifestyle modifications to improve their health, such as controlling diabetes, controlling hypertension, eating a balanced diet, getting exercise, reducing their stress, practicing good sleep hygiene habits, and having a social connection. Lifestyle modifications can improve health, but they are also very important for brain health. Our groups are open to all NVIH patients. We have flyers throughout our clinics of upcoming events. We advertise to our patients via social media and monthly calendars. We also personally invite patients who are on our case management list to join our programs. One of the ways we educate our patients is we host a health series luncheon. This is a monthly educational luncheon with various topics related to monthly public health observances. We invite our providers to present if they have the capacity in their schedules to do so, but for the most part, it's usually a team member from our CHOR team doing the health education. We will present the education, serve a light lunch, and end with a craft activity. We also we also provide education that is curriculum-based, such as DEEP, which is Diabetes Empowerment Education Program. We have members who are, team members who are certified peer educators who can teach the DEEP curriculum to our patients. And in this program, patients will learn about diabetes and how it affects the body and each system, and how to manage diabetes and take back their health. Patients will receive a certificate at the completion of the program. Through our fall prevention program, we offer exercise classes. We've done Tai Chi, chair yoga, matter of balance. And in the past year, our two most popular classes have been interchanging. That is our Healthy Steps program and our Bingo Size program. So Healthy Steps improves physical and emotional well-being by elevating the quality of life through therapeutic exercise and movement, healing the mind, body, and spirit. This program is for 6 weeks and is led by a local instructor who NVIH contracts with for the duration of the program. Bingo Size is a 10-week health promotion program that combines the game of bingo with fall prevention exercise, along with health education trivia. This is a great way for our patients to have a social interaction while playing bingo and learning about ways to prevent falls. This program is facilitated by CHOR staff who have completed bingo size leadership training. So at the beginning of each of these exercise programs, patients are evaluated using the 30-second chair stand, which helps to assess their strength and ability to stand from a sitting position unassisted. Patients are then reevaluated at the end of the program to assess for improvement. Not only do we educate the benefits of healthy diet for one's health, we offer a variety of nutrition programs throughout the year. Currently, we are running our Elders Nutrition workshops. The Elders Nutrition program is being led by Centers for Healthy Communities for 4 weeks. This program promotes healthy habits, a wholesome diet, understanding labels and ingredients, and healthy living. Patients get to watch a live cooking demonstration along with sampling and having a meal to take home at the end of each class. In previous years, Food Smarts cooking classes programs have been held, as well as Kids in the Kitchen program, both with the intention of education on healthy eating habits and learning how to prepare healthy meals. We use culture awareness activities to help with social connection. We've done beading, bear grass braiding. We've gathered elderberry and made elderberry syrup for our patients. Our team has also gathered mugwort, and during our Native American Heritage Gathering this past November, we were taught alongside our patients how to make a salve using mugwort by a local Native American herbalist. To help patients cope with stress, our ACEs program coordinator has been teaching stress busters, and this is a way of learning stress reduction and coping mechanisms. Our future program developments include a memory cafe pilot program. This program would be a 10-week series. It would include brain stimulating and social engagement activities, such as group crossword puzzles. We would start by selecting 5 health topics, and 1 week would be a health education on the topic, on one of the topics, and it would be followed by a group activity. The following week would be utilizing the health education from the previous week. So for example, 1 week we would teach education on healthy brain foods. Then the following week we would prepare the healthy brain foods. And then at the end of that, follow that up with another stimulating social engagement activity. So as the diagnosis of dementia progresses, we want to look at ways that we can support caregivers and also make sure caregivers know how to care for their loved one living with dementia and how to navigate challenges. So in addition to the Memory Cafe, we're looking to implement a caregiver coaching program. 2 of our options that we're currently looking at is the Savvy Caregiver and Reach. We have reached out to Dr. Henderson. He is from Oklahoma for training through the Savvy Caregiver in Indian country. The Savvy Caregiver takes a train the trainer approach, and this program would teach caregivers to know the stage of dementia corresponding to their loved one's functioning and how to adapt to their changing abilities. IHS has just recommended an additional caregiving program that we will be exploring soon. They've suggested, which is Resources for Enhancing Alzheimer's Caregiver Health. And REACH is a dementia caregiving program that empowers caregivers to problem solve challenges they experience from caregiving. So these next 2 phases of our programming development are currently a work in progress. But in the meantime, we're looking at keeping access of care available to our patients. And in doing so, we have been utilizing our mobile medical clinic, and Terry will be sharing this with you.
I would like to just kind of provide a little kind of recap of the grant. So I have to tell you, it was a little, when we first were awarded with it, it was very overwhelming because when you first get a grant, you kind of feel like you have to meet all those deliverables that you set up with. And I would like to just be able to share that what we have shared with you has really happened over the period of a year and a half. And we feel really comfortable with the program that we've developed, that's why we're looking to be able to expand it, to be able to take care of the caregiver. We've done a lot of education with our primary care recently, and we feel that having that buy-in and integration with primary care is going to be at the patient's benefit. So one of the things that we talked about was when we were doing the screening for the fall prevention, that actually went through primary care. And our primary care really came back and said to us, is this one more screening that we're going to have to do? And we decided that we would actually house the screening within community health and outreach. So we had to find out who that population was. And as Jeff shared, we identified an age group of 55. And that age group of 55 really comes from what we've learned from our tribal communities, that they see 55 as considered an elder. And that is probably when most people start experiencing some of their chronicity from their healthcare problems. So we chose 55. And then we were like, how are we going to start educating our patients about this? So as Jeff said, we took advantage of doing that within one of our health series luncheons and started talking to patients about being able to expand that. We also do that with each of our intakes, but right now we are trying to actually partner with IHS and be able to do a few more of those mini COGs to be able to get a feel, like a community feel for is cognitive decline happening and people thinking it's just related to aging? Or is it truly that chronic health problems may be causing, the cognitive decline, and that some lifestyle modifications might, delay the onset or the progression. So what we are really looking to be able to do is pull up a list of patients who kind of meet some of our eligibility qualifiers and invite them to a small like group forum where we do a little bit of education about cognitive decline, what dementia is, to maybe even, discussing Alzheimer's, and then be able to individually take them aside, do a mini cog. And at that point, should somebody be positive, certainly be able to provide them with additional education as to what could be some of the reasoning behind it and support them back to primary care, like Jeff was kind of saying. Additionally, what we're hoping to be able to do is have the providers then begin their evaluation. And one of the things that Dr. Fink shared with us is that providers have many tools themselves that will actually give them that better opportunity to do an evaluation and make that diagnosis. And some of that is the mini mental status exam, the slums, or the MOCA would be three of those that might be utilized. So as we started getting really integrated with primary care, we decided that much like our ACEs screening, much like our fall prevention screening, we wanted to be able to expand this service as well. So as you see here on the screen, we have our picture of our little mobile medical clinic. These were purchased during the time of COVID, and what they did was they served the purpose of us being able to do some testing of our patients early on before the vaccines. And then certainly when we did clinics, this community health and outreach team actually drove that little clinic bus, to sites, and we did some of our mass clinics. And then when the vaccines kind of rolled out and we were on to what the last booster, our services were no longer needed for mass clinics. So these little, mobile clinics kind of sat in our parking lots for a little while. Our team has the opportunity to partner with a lot of our county stakeholders, and they were doing some community needs assessments. And we were so thankful for their partnership, because through that partnership, we really learned that what people were struggling with most after COVID was getting back to their health. And we have one identified area, our Grindstone India Rancheria, which is out in the Elk Creek area, which, when you remember that little map that I had with the star, if you go about 40 minutes west of that star and through very many winding roads, you will come to our Grindstone Rancheria. So for them to access care, it is difficult, because a lot of times transportation was a barrier. And although Northern Valley does offer transportation, we had multiple people who wanted transportation, and still trying to keep people safe. We weren't taking a lot of people. We were just doing one at a time. So we kept our community healthy. So it was decided that we would really take this mobile medical and bring it out to our Grindstone population. And it meant really evaluating what we needed to be able to do. So could that mobile medical get out on those roads? Had it been, maintenance had to come in and make sure it was ready to be able to move and get out there. We have a wonderful staff in Willows that supports that. And most of the time, they're the ones driving that mobile medical clinic out to the site. So I just would like to give a really nice kudos to them, because I don't think I could ever find myself driving this mobile medical unit. The other thing that when we got out there is they were able to identify barriers, right? So one of the barriers is connection. If we bring a mobile medical, how are we going to connect to our electronic health record? So we got our IT team to come out there, and we again want to thank them, because they built this satellite. They gave us access to be able to connect our electronic health record, so we could have that in that moment information for our medical team, as well as the community health and outreach team that was supporting them. So between maintenance and IT, and then our community health and outreach team, designing programs to be out there on that day, so we could bring back people to that social connectedness that Tanya spoke so much about, our community needing. They actually verbalized that in one of our surveys, is that we want to see people, we want to be back together, and we want to do some cultural activities that really kind of bring us back to healing. So it took about a month for us to get the medical team, as well as their support team, our community health and outreach team, all set up. On top of that, we did go back and we asked our tribal partners, how are you feeling about us bringing that there? They were very excited and very supported by that. So we now had their blessings to be up there and provide these services. When we got up there, we realized that sometimes people did not have transportation. So we made sure that community health and outreach worker was there to be able to pick up patients and bring them up to their appointments. And our front desk staff actually sent a person out with us, because they could go ahead and be able to schedule all those appointments, as well as the follow-ups. Our medical team worked really well to make sure we could do some labs up there. Again, trying to remove those barriers of access to care, good quality care that really kind of promote health. We were actually given a lot of warm handoffs by our primary care team to go out there and really get to know our community members through home visits, home safety assessments. And Jeff has actually gone out there a couple times to do some case management with people who are showing some signs of cognitive decline, and be able to talk to them about what kind of things that they can do to be able to prevent that. And now, they're sharing their work with other people. So we may have more opportunities to actually be able to bring groups up there that kind of support that. We bring our House Series luncheon up there. We do an elders nutrition program up there. And we build so many community partnerships that we are now going to be bringing our own health fair out there with more community members. So I think that our community needs assessment has really given us a lot of opportunity in Glenn County to be able to expand that. So as a director, we also are doing this in Calusa, and I'm excited to be able to say that we're looking at how to take our mobile medical services out to Calusa. And in Yolo County, we have partnered up with one of our homeless shelters, and they are asking us to bring out not only behavioral health, but they are asking us to bring out our mobile medical services as well. So in the last 9 months, we've implemented in one place, and we are looking to be able to expand to 2. So I think this is why I just wanted to be able to highlight this and just let people know that this is really the communities like it, and it really helps you be able to expand your services. So we get our fall prevention out there, we get our ACEs out there, we get our Alzheimer's out there, we bring our health series luncheons with do education. We have a student rotation program. It gives them exposure and they learn how to be able to present to communities as well. I would really like to just wrap up by saying that we were very fortunate and grateful to be awarded this opportunity to learn from IHS how to take care of our Native community when it really comes to cognitive decline and the diagnosis of dementia and/or Alzheimer's. They're now helping us progress to how to build a caregiver support team, and we look forward to being able to implement that. As part of our dedication to this, last year we decided that we were going to have a team to walk in the Alzheimer's Walk, which was held on Saturday, October 14th. It's a walk to end Alzheimer's. We asked our NVIH staff to give us recommendations for team names, and then we put it out in a survey. And so I present to you the team Forget-Me-Nots. Okay, I am all set. Thank you.
Thank you, Teresa, Tanya, and Jeffrey. We really appreciate the presentation. So now this is our time for questions. Looks like we had an attendee provide us some really good resources in the chat box. So if you guys are interested in looking at culturally adapted biographical assessment tool, or also the cognitive assessment that also might be helpful for care management approach, there are links in there as well. We do have a hand raised. Teresa, I'm not sure if you want us to unmute you or if you would like me to go ahead and read your question. So if you want us to unmute, if you can unraise your hand, we'll make sure unraise your hand and raise it, and we'll go ahead and unmute you. All right, so I'll go ahead and read off your question just to make sure that we get that addressed. So the classes and workshops that you offered, are they open to all registered patients, or are they just for registered Native patients?
Thank you. That's a great question. We do some of our advertising is really within our clinic. And so a lot of attendees are NVIH patients. And some are, we have a nice showing of both, our Native patients as well as our non-Native patients. And I think that that really presents a nice, great community. We do offer that opportunity to sometimes bring in a support person who is not an NVIH patient. And so oftentimes we will have support people, or sometimes we just have people who show up who see it on our social media advertisements. And so we always put out that there's a number to reach if you have questions, and we would always encourage people to call and contact for any questions.
Awesome, thank you. We do have Alicia making a comment. Great presentation. And I do want to remind the attendees that this webinar is recorded, and we will be posting the presentation slide as well as the recording on the cms.gov in the near future. So again, you can go on cms.gov/American Indian Alaska Native, and you'll be able to find the webinar information there. The next question we have is, this will really basically, this will really help us as we develop activities to address older adult population and working to prevent loneliness. And I would agree. I think the Memory Cafe is an interesting program that you guys offer. And we also have another comment from Iris. She says, our grant employees have actually taken the Savvy Caregiver training. Dr. Henderson is amazing.
Thank you for sharing that.
Yes, another one from Rebecca. She's also has mentioned that they have done both Reach and Savvy Caregiver, and they really like the Savvy Caregiver as it is more engaging. And the next question, I'm not sure if you're able to answer, but are there any newsletters one can sign up for regarding for cognitive loss or links to resources for that?
I want to say that the Dementia Care Aware website would be an excellent resource for people who are looking for some of that information. And I don't know if Jeff or Tanya have anything more to kind of add on to that.
Yep, and I do see Jeffrey kind of typing in, so he may be able to provide some links if possible to that question.
Okay.
Next from Lita, is your community needs assessment for this area available for review?
Our community needs assessment that happened in Glenn County as well as Colusa was really completed by a third-party consultant to the community, whoever connected with their public health. We just happened to be invited to the table to be a participant in the community needs, as well as once the community needs were released, we were there to be able to identify top strategies and goals. And then the next step will be creating the community plan. And I think at that point, they may be releasing that out to the public.
Great, thank you. And we also have another comment here from Eric. He says, thank you very much for this informative webinar and for all your work in advocacy. So some of his students were unable to attend today's webinar due to class schedules. But again, Eric, go ahead and check our cms.gov website for the recording as well as slides. Next one is from Timmy. So how do you determine your staff between a CHR and a CHW or community health worker?
Yeah, another great question. We get this asked all the time. So they really are equivalently the same. I think IHS has called them community health representatives. But if you look at what the community health representative training is offered through IHS, it aligns with a certificate program for community health worker, acknowledging those 13 competencies that they would have to do as well. So we just kind of see it the same. How we do it is we start somebody in Northern Valley as a community health worker. And as we're building their toolkit, right? So learning that fall prevention, how to do the home safety assessment, how to do the mini cog, how to do a home visit, then they get sent out to either take the CHR training through IHS or they'll take a certificate program, and then we bring them up to a CHR. So we just look at it as an advancement in training.
Okay, great. Next, we have a couple of questions from another attendee. So this may have been mentioned, but can you elaborate a little bit on the Bingo Design program that you offered in your events calendar?
All right, so bingo size. Tanya, you got this one?
Yes, so it's a 10-week health promotion program. And what it does is it combines the game of bingo Everybody loves bingo, and it's one of our popular programs that we do. So it is combined with bingo and then fall prevention exercises. So a little bit of chair yoga, maybe some healthy steps, maybe some TheraBand exercises, and then there's also a component of trivia worked into there too. So I think it goes for an hour. It's an hour program. And it's a great way for everybody to socialize and have fun. So, you know, they're exercising, they're thinking, and they're playing bingo.
Awesome. The
And
next question.
there is
go
a
for it.
training program for bingo size.
Awesome, amazing. The next question was, is there a specific training course for those who want to teach the Savvy Caregiver course? And I also did see that Jeffrey did put the link to the program in the chat as well, but I don't know if any of you guys also want to elaborate on specific training course that they may be offered.
So we're just looking at this, right? We're at the beginning stages of looking at it. My understanding is they come in and teach you how to be, it's a train the trainer type situation. So it would be, it's a training for caregivers that we would give. So we'll take this training and how to facilitate this training. And I think that if somebody else wanted to look at it, you could look at the Alzheimer's Association, as well as your Agency on Aging, because they offer a lot of resources for that as well.
Perfect.
And I believe there's two different variations. There's the Savvy Caregiver, and then there's the Savvy Caregiver in Indian country.
Oh, great. And I think the one he put in the chat was the Indian country, correct?
Mm-hmm.
Correct. Okay. Another question we had coming in is from another attendee. We are trying to improve discussions with the elderly population on substance abuse. Can you share any methods you have tried that may have been successful?
So our behavioral health department really does what they call a talking circle. And I think that opens up that opportunity for patients to gather, feel a sense of community and connectedness, and be able to kind of talk about that under the facilitation of either our life skills coaches that have a foundation in behavioral health, or a behavioral health therapist. That doesn't always fall in our wheelhouse to do that big education. We'll bring in people to offer that support and education.
Okay. Nancy also asked a question, who performs the mini cog assessment? Is it only done in the clinic, or can that also be done in the home?
It can be done in the home. It is part of the CHRs toolkit, so they can do it anywhere. Clinic, community, in the home, over the phone, except for the drawing of the clock. They could do a quick little, here's 3 words, and then talk to them about something, do 3 words later. I also want to acknowledge right now, there is somebody who is an anonymous attendee, providing us with some culturally adapted cognitive assessments and some articles and things like that. We just really want to say thank you very much. We appreciate that. I'm trying to download them as fast as I can.
For sure. Teresa, another comment she has, good presentation. Thank you, Northern Valley Indian Health. On a side note, and in general, tribes in California are lowering their elders' age from 65 to 55. So glad to hear you're on board as well. Another question we have is, our dementia program also has a dementia bingo that goes with our community PowerPoint, so they loved it as well. I will go ahead and read one last question since we're almost at time. So Eric has a question here. Have you considered incorporating screenings for elements of subjective cognitive decline and mild cognitive impairment, in addition for screenings for potential dementia? this might be helpful inclusion for people in their 50s and 60s.
And I would like to say thank you for that. You know, it's such a new program that sometimes I always say to the staff, we don't even know what we don't even know. And so, right, even though we're sharing things from you, we're certainly learning a lot back as well. This grant ends at the end of August, but my understanding is that they will have an opportunity for us to rewrite for another 2 years. And I would love to be able to consider that. We would do a mini cog on somebody earlier than 55 of age if they expressed a, you know, a change in their health condition, or if, you know, certainly the providers kind of asked us to be able to do one due to, you know, them feeling like they wanted that assessment. So thank you, Eric. We appreciate that. And I just want to acknowledge Timmy. Thank you very much as well. I don't know that we're ready for the big conference. I think that we really appreciate, again, Nicole and her team for being able to, you know, have us on board to be able to present this program.
Perfect. Well, again, we are at time right now, so I would really like to thank Teresa, Tanya, and Jeffrey for joining us today, as well as the rest of the staff that were able to join the call. So in closing, I just wanted to quickly remind everyone that today's webinar was recorded and that the audio and presentation slides will be made available online at cms.gov. So again, thank you again for joining today's webinar. Our session is now concluded.